The opioid epidemic. How can ED providers help? So what I've done is an assessment of the clinical problem. From July 2016 through September 27th, there was a 30% increase in ED visits from opioid overdoses. For drug overdose deaths in 2016, there were 63,632 reported deaths in the U.S., which is 21.5% higher from 2015 to 2016. From 2015 to 2016, the opioid-related overdose deaths had risen 27.7%. Prescription opioids account for more than 40% of all U.S. opioid overdose deaths in 2016. More than 46 people die every day from an overdose involving prescribed opiates. Opioid-related visits from the ED department have been steadily rising due to patients from rural areas needing a higher level of care and more resources. Emergency departments should be able to focus on evaluating and stabilizing seriously ill and injured patients, but now they also struggle to deal with overdoses and addiction issues. These situations affect physicians, nurses, and patients alike. So what is the link? The link is that emergency departments are places where the interventions and preventions can be applied when handling patients with opioid-driven chief complaints. At ECMC, they have established a medication-assisted addiction treatment, and this is a form of MAT that allows staff to screen for the ability of patients to participate in MAT. This participation ensures patients are discharged with a treatment plan and a short-term supply of bupropion or a dose of Vivitrol, as well as a referral appointment for addiction services. At United Memorial Medical Center, even though they are part of the Rochester Regional Health System, they do not have a program implemented at this time for the treatment of patients with opioid-driven chief complaints, or those with addiction, or those being treated for overdose. This emergency department only provides a list of resources available in the area, such as Tujacasa and Horizons Treatment Services, with the typical discharge instructions for pain management and overdose. This system that they're using here is what ECMC and other health providers in our area had been using for many years, and it just was not effective. Implementation of the opiate administration guidelines would help the emergency department provide the opportunity for the intervention and prevention, which would help decrease the repeat visits that can occur. Among emergency department frequent users, what's the impact of posted opiate administration guidelines on repeat opioid-driven chief complaints? So the population is the emergency department. The intervention is the implementation of the opiate administration guidelines. This would be by giving pamphlets to patients about alternative treatments, post signage containing the guidelines throughout the departments as well. And for a comparison, we could compare patients who have not been provided the information of the guidelines and what their alternate measures are to treat their pain complaints. An outcome of interest would be decreased repeat visits of patients coming to the ED department with opioid-driven chief complaints. And the time frame would be 3 months after implementation that we would review the data. First, I looked at the synthesis study, which is qualitative, and it's about the analgesic use by aging and elderly patients with chronic non-malignant pain. This study was developed to identify a patient's perceptions and experiences of analgesic influence for their use when treating chronic non-malignant pain, and how these factors influence the way the analgesia is used. There are numerous barriers to treating a patient with non-malignant chronic pain, from the geography, are they able to access services, economics, of course, co-pays, is it covered by the insurance, things like that, and just a lack of knowledge of their illness and alternative methods to treat the pain. Healthcare providers need to be aware of these factors, as well as the patient's perceptions and experience, to better treat the patient population. Having healthcare providers that are more knowledgeable about the patient's perceptions and experiences in order to look at each patient and develop a plan of care that addresses their needs appropriate is very relevant. Study number 2 is about enhancing screening, brief intervention, and referral to treatment among socioeconomically disadvantaged patients. So this study was to determine how a knowledge application of the SBIRT and the use of the knowledge translation can enhance a patient's satisfaction when they are low-income patients with substance abuse issues. The community engagement and knowledge application would be beneficial to providing for this population. There's a greater need to extend into best practices, given the difficult population being served. Patients with substance abuse tend to not have trust in those treating them, and patients are focused on the continuity of care and addiction services, especially seeing that continuity care is important, given that these folks tend to be more transient and they are searching for that consistency. Article number 3 is about the initiation of the SBIRT, alcohol and opioid training for nurses employed on an inpatient med-surg unit. So the RNs on the inpatient med-surg units need to have better preparation on how to initiate the SBIRT, CWA, and COWS. RNs self-reported and demonstrated the ability to initiate SBIRT and provide motivational interviews after they receive some simulation training and some didactic training. The relevance of this data is that it shows that continued education of nurses on med-surg units improved their ability to confidently identify and interview patients with substance and alcohol abuse issues. Article number 4 is a randomized control of a citywide emergency department's care coordination program to reduce prescription opioid-related ED visits. So in this study, they looked at the increasing prescription overdose deaths that have demonstrated the need for safer emergency department prescribing practices for patients who are frequent ED users. In this, they found that a citywide care coordination program decreased the ED visits and as well decreased the controlled substance prescriptions. And the relevance of this is that the ED departments play an active role in providing interventions and the prevention measures that can positively impact our community members, the patients and the families both. So proposed changes to practice would be the resources that are needed, the effects on those involved, the plan to implement, the outcome, and the evaluation. So the resources needed would be the creation of literature and signage, a committee developed to decide what pieces of alternative information for therapy are we going to provide, when it's going to be provided, some staff education tools, how are we going to implement this throughout the staff, are we going to do in-services, are they just going to have readings with tests, things like that. So we're going to have implementation guidelines, when we're going to roll it out, how we're going to roll it out. And of course we need the approval from the physicians and the hospital board. The effects on those involved, the folks involved in this would be the nurses, the patients, the family members of the patients, the physicians, administration, and of course community members. Risks and benefits. The risk for this change would be that the frequency of repeat visits related to pain and opioid-driven complaints could remain unchanged, but the benefit for this change would be that the frequency of these repeat visits, of course, would be decreased. So the plan to implement would be to put together a committee of ED staff members who would help to design the literature in a pamphlet and poster form. Staff members would be used, or are used, to gather data from previous admissions. We would assure that the staff is aware of who will partake in the implementation and use a team approach to be sure everyone is following the guidelines that have been set forth. The guidelines will be distributed upon admissions to the department by the admissions staff and then reinforced by the rest of the staff members. Training would take place through simulation, didactic, or in services. All new employees would also be trained upon hiring to ensure some continuity and no gaps. Training would be updated every 6 months as part of the reinforcement. The outcome measurement would be 3 months after the implementation of the Opioid Administration Guidelines. The data of admissions to the ED department for patients with repeat opioid-driven chief complaints will be compiled. And this pre- and post-implementation data will be compared to see if the number of repeat visits have decreased since the implementation began. For the evaluation of changes, after 3 months of implementation, the data was compiled in regards to repeat ED visits with opioid-driven chief complaints, and the number of visits decreased. The pre-implementation visits were a number 76, and that was in 3 months prior to implementation. And 3 months post-implementation, there were only 58 repeat opioid-driven visits during this time. So adaptation of changes. The implementation of these changes would be worth adapting. The cost is cost-effective to continue. The changes would only incur minimal fees and budgetary needs, and that would be like the cost of printing, and of course there's some expense that goes along with the training. And as part of the adaptation, with the early implementation showing promising numbers, it proves that this project would be a worthwhile endeavor to help educate our consumers. So to integrate and maintain this guideline, we would be sure to provide staff physicians and nurses with numerous alternatives on how to learn and obtain the information about the guidelines, provide staff with up-to-date data on the results. Of course, initially we would only have the pre- and post-implementation data to show, but at least it would reinforce that this is working. For integrating and maintaining, all new employees would be required to go through this training during orientation, and it would be required to be updated biannually by all staff. To develop the Opioid Administration Guidelines as part of the standard policies and procedures for the department. And also we would want to monitor the data for effectiveness against repeat visits and reevaluate the data every 3 to 6 months to make sure that we are still using the appropriate guidelines. Thank you.